Right, thank you, Dr. Rita. And now that we've gone through what to do and where to cut and how to do it, and we've all done our good surgery, but is your job really done? Unfortunately, in contrast, and that's what Dr. Harsh said, the advantage of glaucoma surgery is that, or glaucoma practice is that your patients are never done with. So especially for glaucoma surgery, once you do it, it's beginning of a process that takes several months to complete. So please remember that. Alterations in bleb morphology and aqueous outflow due to the scarring response always influence long-term success, and appropriate management at the appropriate time is essential to ensure a good filtering bleb. So what is the ideal trabeculectomy? We'd all love to see all our trabs look like this. You'd like diffuse, mildly elevated blebs with normal conjunctival vasculature. You'd like to see visible fluid in them, as you can see here, yet the scleral flap mildly visible, well-formed AC, tightly closed conjunctival wound, and a patent sclerostomy. And believe you me, this is a miraculous surgery to achieve. And what we definitely do not want, and we can predict and manage in time, are situations like this. Your tenons could scar down with your conjunctiva. You could have an absolute localized tenon cyst. Very, very dangerous looking thin cystic blebs, especially seen with mitomycin. It's like a red hot bomb which can burst at any time. And if there is hypotony and there is a small thing here, if you don't manage it in time, you see the sedals that is positive. So if you know what is happening, then you can manage it well. But then you don't want these. So I'll go through a usual post-operative course of what we do. How often is follow-up required? Initially, unfortunately, you require very frequent monitoring because it allows changes in the bleb characteristics to be identified, and there is an early window of opportunity which exists to modulate these changes. So the first 6 to 8 weeks are really, really crucial. So if you have somebody who's saying, operate me today and I'm going to go to the US next week, the answer should be get yourself operated in the US then. Do not do something if you cannot follow it up to its logical conclusion. Weekly for the first month, this is a typical sort of follow-up, 2 weekly for another month, and then depending upon the bleb and the intraocular pressure and the status of glaucoma. So the first 8 weeks are really, really important, and if you do that well from the first post-op day to maybe at the end of 6 to 8 weeks, you're pretty much all right. So on the first post-op day, expect a moderate bit of inflammation. Frequent topical steroids and cycloplegics are necessary because you've done a lot of cutting. There could be some bleeding there, and usually these are eyes which have been on topical medication for a long time and the ocular surface is not so healthy usually. If the IOP is high on the first post-operative day, it's a good thing. I would prefer a higher IOP on the first post-op day than a lower IOP because a higher IOP is easier to deal with, and the secondary aqueous is the one which you don't want after hypotony. So the ideal pressure would be at least in the mid-teens or maybe even a little higher, and those are the trabs which you'll realize do well. However, if it is going into the mid-20s or it's a little bit more than you would like, what would help is a gentle digital massage on the first post-op day. Now this is somebody like that. So 24 pressures and just a digital massage rather than do it inferior limbus, because then there is a tendency for the iris to get stuck in your sclerostomy. It's a nice practice to do a digital massage just adjacent to your scleral flap. So where you've made the scleral flap, press momentarily on normal sclera. The flap just opens up for a second and allows a little bit of aqueous to egress out. It's a fresh wound. You don't need to do anything else. It takes about 5 seconds to do that, and believe me, in the first few days, that's all that is required. It has resulted in fluid coming into this. So this is on the first day, just one digital massage because it has fish-mouthed the scleral flap. Better to have the IOP in the mid-teens, as I say, but be very careful not to be very aggressive in case you shallow the anterior chamber. So at the end of the first post-op week, usually, if you have, especially in young patients and secondary glaucomas, you would have some amount of corkscrewing. If it's excessively corkscrewed or inflamed, we do use subconjunctival 5-FU. What is given is 5 milligram and 0.1 cc. You have 5 fluorouracil available as 25 milligrams or 50 milligrams. So it's 25 milligram in 5 ml or 50 milligram in 10 ml. So the concentration is exactly what you want. You don't need to dilute it at all. take out 0.1 ml in an insulin syringe and just inject it away from the bleb. We usually do it up in the superior fornix so that it's not directly into the bleb. But I want to share something which had happened when we were a little careless, so be sure that the IOP is not too low. If at all you have to inject your 5-FU, it's better to do it after your manipulations. If you want to remove a suture or you want to give a massage, because if you inject your 5-FU and then do manipulation, the sudden hypotony will draw it into the anterior chamber. We learned this the hard way in one of our cases. I keep showing that. It instantly becomes gray and it stays like that, and your heart is in your mouth for some time. But at the end of about 4 to 6 weeks, it does clear up. But we don't want this happening. So this is typical toxicity of 5-FU. So be very careful. It's not as innocuous as you would like to believe. Now, when do we manipulate the sutures? The releasable suture that we've given. Remember, our suturing has been very tight to ensure moderate intraocular pressures, immediate post-op, and avoidance of hypotony at any cost. So if the IOP is still high or pressure is required for massage and you can't do it well, you can release a suture. Usually release it within the first week, at the most within the next week or so, because after 2 weeks usually the suture starts getting scarred in that scar tissue and it might break if you take it out. So if you have to release it, the first 2 weeks are better to do that. So there's a small suture there and you can just use a McPherson, ask the patient to look down and gently pull it out. Usually it comes out easily. And you can almost see the bleb being formed here. As you see, it was flat, and as we've taken out the suture, and here the fluid has come in. So you can see the bleb coming out as you're taking out the suture. So the typical course in young patients is something like this. Day 1, when we've just given them frequent steroids. Day 7, with the corkscrew vessels there, suture removal and injection 5-FU. And by day 21, the corkscrewing, you can see, has become straightened. Corkscrewing is an indication that the scar tissue below that has started fibrosing and it is pulling on the conjunctival vessels below it. So it's a sign that already subconjunctival scarring is beginning to happen. 5-fluorouracil as an anti-fibrosis agent is likely to halt that then and there. Now, what if the IOP is low? First is look at the bleb. Look at what the problem is. Usually it is overfiltration, which requires just a pressure patch, some atropine. But if there is lens corneal touch, only then you require an AC reformation. But by and large, the majority of them get all right with just conservative measures. Look for choroidal detachments. The problem with choroidal effusions are it's a chicken and an egg phenomenon. You're not sure whether the low IOP is due to the choroidal detachment or the choroidal detachment is due to the IOP. But whatever it is, it usually settles with steroids and atropine. Now, if it's whether it's with a shallow AC, look actively for a leak. This is the patient that I showed you before. If there is a leak, that requires appropriate management immediately. There's no point in hoping that this leak will settle on its own. It won't. It needs to be taken back to the OR and resutured in time. Now, trabeculectomy can be very frustrating, and I'm sharing with you this interesting study that I read. 119 trabeculectomies were followed up for a year, and 78% of them were followed by some form of bleb manipulation. So almost close to 80% of all trabeculectomies need their blebs to be manipulated to ensure that they function well. 49%, almost half of them, required massage on day 1. 49% again, about half of them, required suture removal by week 1. 31%, about 1/3, required at least one 5-FU injection, and the usual time to give it was around day 14. And 1/4 of them, 25%, required at least one needling and one 5-FU, and the approximate day was about 6 weeks, day 43. So post-op intervention is frequent after glaucoma surgery, and there's nothing abnormal or bad that you've done just because your blebs need manipulation. Your blebs need to be nurtured, otherwise they're not going to survive. It requires intensive post-operative follow-up, and the conclusion was glaucoma surgery is a very labor-intensive undertaking. So what should one look for? I'll just take half a minute more. Several indicators that point to the risk of bleb failure. Look for them if there's excessive conjunctival injection, if there's corkscrewing of vessels, and if there's increasing IOP, ask yourself why, rather than a knee-jerk of just giving a drug, even though there's so many available. One is a high bleb phase, typically seen at 6 weeks and need to give aqueous suppressants to salvage it. Flattening of the bleb is probably due to inadequate filtration. You need to consider needling for that. But before all that, look at the sclerostomy. Put in your gonioscope. If your sclerostomy is not patent, no amount of manipulation of a bleb beyond that is going to work. So clinically see whether your sclerostomy is open, see whether an iris has gone into it, and if it's that, address the cause of whatever the problem is. So this is just to show you a high bleb phase. This is POD1, typically again seen in young patients. This is POD7, post-op day 7 after the 5-FU injection. But at 6 weeks, the intraocular pressure rose to about 26. And you can see here this bleb is getting high and is getting very localized. So if you can salvage it now, at 10 weeks, the bleb is settling. We just started timolol in this. What happens is the microcysts inside the conjunctiva get flattened. The microcysts are the conduit for the aqueous to go out into the subconjunctival space. So if you have that flattening, that route is blocked. So the aqueous keeps coming into the bleb and raises it and makes it a high bleb phase. So at that point of time, what you actually paradoxically need is the aqueous to be suppressed so that the microcysts inside that bleb form again and the conduit to get out is re-established. And if you do that, when the bleb height is less, the intraocular pressure is 14, and then the timolol is gradually stopped. But you need to recognize this, and this typically happens commonly at about 6 weeks' time. And by 4 months on no drugs, the bleb is diffuse again, the IOP is 16 millimeters. So small recognitions of problems have simple solutions if we know what is happening. This is just to demonstrate in case Ologen is used. Remember that Ologen does tend to press upon your scleral flap and reduce the aqueous outflow. It requires more massage than usual. So by PO day 7, you really need to work a little more if you have an Ologen. I've realized that they need more massages than ever because you need that aqueous to filter out and then it settles in well. So this is at 3 months, this is at 6 months, 1 year and 18 months down the line. A pseudo exfoliation with very thin conjunctiva. We chose Ologen because we thought MMC would be a bad thing for an elderly lady with pseudo exfoliation and with a very, very thin conjunctiva at that. So to summarize, the trabeculectomy is just the beginning. It is step 1 of a process aimed at achieving a satisfactory bleb morphology. For some trabeculectomies, the post-op period involves many adjustments. Each of the various interventions has a specific role. Recognition of bleb morphology is the basis of intervening appropriately. That's the key word. And it's a sobering fact that despite all that you do, some of your trabeculectomies still fail. Thank you.